Okay. So what I'm handing out, so I've had a couple of questions about search terms and search parameters, and so I'm handing you these two things out that I got from, I took my general psych class to the orientation, or like an orientation session at the library, and they were amazing. And so if you've never had the opportunity to go and talk with any of the research librarians, I highly recommend that you make time to do that, because they have great ideas on how to ask your research questions, search for the search terms that you need, sort of broaden your search if you're having a hard time finding things. And I thought if I handed these out, then maybe it would help out generally for you all. Did you find it helpful? Okay, were you able to find more articles after we had that conversation? Okay, perfect. Okay, so I'll just briefly talk to you about these things. The first, this sheet right here is a way for you to ask your question. Oh, yeah, grab one of each. To develop your research question and then come up with the different synonyms for each of your research terms, right? So if I was going to be doing anxiety and empathy, then I might look up nervousness or generalized, like the different types of anxiety. And for empathy, I might look up conscientiousness or some other terms like that. So it gives you a clear way to brainstorm your terms, because I think that's the most helpful thing in broadening your parameters. So if someone says, I can't find enough articles, this is the way you go about finding some more articles, right? So I encourage you to come up with some synonyms for the different terms that you're using, the big anchors for your research study. And then it's got a handy dandy little log back here where you can look at the things that you've looked up, look at the things that you've searched by. JK, sorry, you don't get the log. There's a log, but you should, okay, I didn't make copies of the log. I'm sorry, it was two-sided and I didn't know. Never mind. I would encourage you to make a log of the things that you're looking up, like the different terms that you use, the different search terms that you use. You don't have to have a log to do that. You don't really need this. Just do that. Keep a log. So like when I do grant searches, because I really want to find some money to get this project going that I want to do. So I'll go in and I have a spreadsheet that I've made, and so I'll look at the different funding sources that I've looked at, the keywords that I've searched by, so that I'm not covering the same ground over and over again, right? So just have some sort of system for that, okay? This is pro tips on just sort of how to use the search engines. And so there's a handy one. Let me do this. So if you're used to looking only in like psych articles or psych info, that was sort of where I was comfortable. That was the swimming pool that I was swimming in. But what she recommended, oh man, that's not what I wanted. Hold on just a second, let me see if it's here. No, but we have these handy dandy things. Let me go to the library real quick. There's a discover function that Tarleton has. And you can broadly search through a variety of different types of journals, and it's really, really helpful because it tells you if it's a journal or if it's not, if it's just a popular article, or if it's, so it categorizes your research, the things that it finds. Whoops. This is it right here, right? So you can search by keyword, you can search by title, you can search by author, and then it searches all of the databases. So what was it that we were looking at, and I told you it might be in like a different type of a journal? Do you remember? Tell me what your topic is again. I'll remember. Oh yeah. So we were looking at. So she's looking at stress among college students, parents versus non-parents, right? So we were looking in psychology articles, but really student affairs journals might also have things like NASPA's journals or some of the other student affairs organizations. So that might have been a pool that we needed to like dive into and swim around in to see if we could find some articles. And so by searching through discovery instead of psych info or psych articles, you can also find some really good information. So if you're struggling to find your 10 articles, these are the kinds of things that I suggested you look at. Questions about this before we start on abnormal psychology? Okay. The other thing that I want to, kind of housekeeping thing, what we're going to do on Wednesday is, on Wednesday we're going to do a practice test for the major field test. I'm going to give you a practice test, and we're going to score it up, we're going to talk about it, and I'm going to talk to you specifically about how to go about registering for it. We've bought the inventory, it's in, I can create my cohorts, and I'll get in touch with Emily Morgan, and we'll get you information specifically on how to register for your time to take the major field test. Okay? Okay. And last housekeeping item. I've had a couple of questions about quiz questions. Has anybody come across a wonky quiz question yet? Okay, if you come across a wonky quiz question, screenshot it for me or write it down for me so that I can give feedback to the publisher of the textbook. There are some questions that I don't think are great. And a lot of our quizzes are drawn from pools of questions instead of being specific questions. And I like that because it adds variety and it hits different topics. But every once in a while you come across a real strange one. And so like in my general psych class, which uses the same textbook, which is the reason I bring it up, there was a question, and it was really on this, it was a cognitions concept, and it was asking about the structure of an airplane. And nobody could figure out how it even related to the concept, but it was related to an archetype thing. But anyway, if you come across something super wonky, or you think it's wrong, or you have an issue with it, send me a screenshot, or write it down, or and we can go to my office and we can look at it. Okay? Is it perfect? No. Our textbook's not perfect. So if there's feedback that needs to be given, let me know. And I'll send them a message and say, you need to do an item analysis and probably throw this item out. Okay? All right. So today, we're going to talk about abnormal and clinical psychology. This is my jam. I love it. This is my favorite thing to talk about. But there's a lot to talk about. So even though I don't love to talk at people, I'm going to talk at you for the next hour to try to get all the information. But please, please, please stop me and ask me questions if you have questions or if you want some clarity, okay? So in that major field test, instead of just looking at abnormal psychology features like we do in our abnormal classes, the way our abnormal classes are structured, they're interested not only in just the features of the different disorders, but they are also interested in treatment modalities. So I'm going to touch on treatment modalities as well. I have sat for the major field test-ish. It was a review copy, so it wasn't the full version once. And so I have an idea about the kinds of questions they ask, so I've tried to structure this in such a way that you will get as much information as will be helpful. But it also pulls from a pool, so we don't have all the information. How many of you have heard of the DSM-5? Raise your hand high. How many of you have heard of the ICD-10? Okay, that's what I thought. So the DSM-5 gives us the information that we need. It gives us common language to talk about the psychological disorders. It gives me the information so that if I say to you social anxiety, you have a conceptual framework for what that means, right? And that's really, really, really important because before the DSM, we didn't really have that, right? If you think about Sigmund Freud, he was sort of working in a nebulous world where things were just bad, right? People had pathology or they didn't have pathology, and it was from some mysterious unconscious function. So this has given us this language. So the DSM-5 came out in, 2013, I think? Before that, we used the DSM-4-TR. The DSM-4-TR had our diagnostic function was 5-axis. So on axis 1, we would put whatever disorder we were looking at. Anxiety, depression, you would put all of them. Everything that you thought was going on. Schizophrenia. On axis 2, we put down the more pervasive things like personality disorders or intellectual disabilities, things like that, right? So you can sort of think of some of the disorders as conceptually more transient or episodic, and then more the second sorry, I can't talk at all. The second axis as more pervasive and sort of less episodic. That's going to be more chronological or what's the word I'm looking for? Chronic. Right. Okay. So it provides us 256 diagnoses. The difference is the ICD-10 It's an international statistical thing, and it has 14,000 diagnoses, all diagnoses, including things like, I don't know, physiological impact of being sucked into a jet engine second time, right? So if you, anything you can think of is probably classified somewhere in the ICD-10. This provides the code numbers that psychologists use for insurance billing. So if you ever go to the doctor's office and they give you that one little sheet and it's got all these little codes on it and they circle what the different things are, like sinus infection, or you know what I'm talking about, that one sheet that they give you as a receipt, that's ICD-10 codes, right? And so our entire insurance system is built along the lines of the ICD-10. So they're pretty compatible. The DSM-5 gives us a lot more information than the ICD-10. The ICD-10 gives us the standardized billing codes that we use. So know that there are both of those things. There are lots of classifications. Obviously, in this next hour, I'm not going to be able to cover everything in detail, right? I'm going to try to hit the highlights of the things that I want you to be most familiar with, and then I'm going to let you fill in those gaps. And I hope that on Wednesday, when we do the practice test, it will illustrate to you how important it is that you are going to have gaps in your knowledge at this point, and that you're going to need to do a little study to work on filling those in. Okay, so the first classification that we're going to talk about are the neurodevelopmental disorders. These were formerly called diagnoses first found in childhood, right? And there are they have rearranged a couple of things in the DSM-5 from the previous version, the DSM-4, including, and I think this is probably the most important one, moving attention deficit hyperactivity disorder out of the impulse control disorders and into a neurodevelopmental disorder. The more we know about neurodevelopment and the more neuro research we get, the more we're seeing that there are neurological differences in children with ADHD versus just children who are the result of difficult parenting or problems with parenting, okay? So we've moved this away from disorders like oppositional defiant disorder, right? Have you heard of oppositional defiant disorder? So there has been an intentional separation of those two. That's the big one that they've really worked to separate out. So we know that ADHD is much closer to autism spectrum disorder and communication disorders than it is to oppositional defiance, even though they are often comorbid, okay, in etiology. So do you know what the different subtypes of ADHD are? How many of you are in abnormal now? How many of you had abnormal? Okay. What are the subtypes of ADHD? Surely you got this one. This is easy.
I don't think my teacher went over that.
The different subtypes?
I have noticed.
I don't know.
I think that cost was on. Yeah, he's on here anyway.
Okay. Okay. So there are two different subtypes. Well, there's really three. But there's inattentive, right? So you got the child who has a really hard time sitting in class and paying attention, or the adult, because these things are not specific to children. They're mostly first identified in children, but I know lots of adults with ADHD. So the inattentive subtype is the person who is really disorganized, really messy, has a really hard time focusing and paying attention in class, just really has a hard time creating this executive function of, I need to do this and this and this and this, and then executing those steps in their brain, right? They have to externalize everything. So we've got the inattentive subtype, and then we've got the hyperactive impulsive subtype. Those are the kids that you think of as more typically ADHD, bouncing off the walls, climbing, can't sit still, need to be moving all the time, right? Interrupting the teacher, having a really difficult time controlling their impulse to make everybody laugh, right? So that is the hyperactive impulsive subtype, and then there's a combined subtype. So there are three different types of ADHD. Have you heard of somebody say ADD instead of ADHD? Yeah? So the inattentive type is what people commonly refer to as ADD. Officially, in the DSM, there's no such thing as ADD. No such thing as ADD by itself. It is inattentive subtype of ADHD. Okay? That's important. Know that. We've also got, I think it's important for you to know that intellectual disability used to be called mental retardation, but Rose's Law changed that. So Rose's Law came into effect probably around the same time I came here, so about 4 or 5 years ago. Rosa's Law changed the vernacular, right? So, and that's pretty common in this field. So we used to call people imbeciles or idiots or, like those were the common language. And then they became pejorative. And so then the rhetoric shifted. And that just happens periodically. It's not something that it's just something that happens generally. So know that if you were looking up intellectual disability, that is the same thing as what used to be called mental retardation. Retardation has become pejorative, right? And people use it as an insult all the time. And so Rosa's Law sought to change that. Okay? And so even in Texas, we have MHMR. Have you heard of MHMR? So MHMR is mental health, mental retardation. It's a whole state agency. They are moving away from the language of MR because MR is not the parlance anymore. We also, one of the big shifts from DSM-4 to DSM-5 was related to autism spectrum disorder. So within autism spectrum disorder, we used to have autism, Asperger's disorder, and what we called PDD-NOS, which is pervasive developmental disorder not otherwise specified, right? Which is the child who exhibits many of the characteristics but not enough to meet the diagnostic threshold for Asperger's or autism, right? But is enough to feel to have some impaired functioning. So this most recent version of the DSM transitioned from having those categories to having a dimensional model, right? So instead of a categorical model, the DSM-5 is trying to transition to more of a dimensional model. So instead of having those different categories, we just have the autism spectrum, right? And you look at how severely impaired the functioning is within the broad umbrella of autism spectrum, okay? The PDD-NOS has sort of really moved more to the social pragmatic communication. So social pragmatic communication would be those people who have impaired communication difficulty, functioning in a regular social back and forth interaction, have difficulty with what we would call theory of mind. Does anybody know what theory of mind is? Theory of mind? I think I might have talked about it like last week in terms of development.
Is it like when knowing someone else can't, like, that somebody else can't know what you know?
Yes. So theory of mind is recognizing the distinction between my mind and your mind. So if I put candles in a box of crayons and I have a stuffed animal that's in another room, and I bring the stuffed animal back in and I say to the person, what will the stuffed animal think is in this box of crayons? Right? Somebody who really struggles with theory of mind will say it's crayons. No. Yeah, wait.
Of course he knows it's candles, even though there's no possible...
Right, no, yeah, yes. Okay, so somebody who struggles with theory of mind will say it's candles. He'll know it's candles because I've seen the candles, right? He won't know that because the bear hasn't seen that it's candles. That it's candles. I think I twisted my brain up for a second. Yeah.
Okay.
Yes.
There's a lot of similarity between the communication disorders and ASD.
So that's a great question. We're talking about thresholds, right?
Right.
So theory of mind is going to definitely be most likely going to be present in any of the autism spectrum disorders, but if they don't have any of the other things like stereotype behaviors or restricted and repetitive interests, they just have that difficulty with theory of mind and social communication, it would be here. If they have the restricted and repetitive interests, if they have the stereotyped behaviors, and if they have the really specific impairments, like I can't make eye contact with you, then this is just a lower level. It's a lower threshold. It's definitely going to be here, but it's a lower threshold.
So
what are you
where
thinking?
would like the really high functioning Asperger's, I guess that's where kind of all of the hype came up with the new DSM-5.
Yes, absolutely.
They're now, a lot of them would not be classified ASD.
Correct.
They would be under...
Correct. Yes, it was very controversial. And there were a lot of parent groups, especially ASPE, like ASPE moms and ASPE groups. So ASPE is short for Asperger's, and it's a group that that's a term that the community has identified as one that they identify with. But anyway, ASPE moms were really fighting against that, because then they sort of fell out of the umbrella of protection
Services.
for the under DSM. Yeah, it was a real problem, and it's still not settled. This is not something that the field is broadly settled on, right? I suspect we'll have a DSM 5.1. So when we moved from DSM 4, 4 was a Roman numeral. Now we have DSM 5. 5 is an Arabic numeral, right? You know the difference between Roman numerals and Arabic numerals. And they did that because they wanted to align more with sort of the model of 5.1, 5.2, 5.3. So they transitioned. Instead of DSM 4 TR, right, which was text review, they moved to the 5 points. So they could do that. Okay. The other thing that I will point out, man, I got to go faster through my slides. Specific learning disorder is where the term dyslexia would fall, right? You've heard of dyslexia. Everybody's heard of dyslexia. Dyslexia is not a specific term from the DSM-5. Not. Reading disorder is. And then when you measure reading disorders or learning disorders generally, the field has moved from, again, categorical sort of test them and tell them. I'm going to measure your IQ, and then I'm going to measure your academic performance. And if your academic performance in reading doesn't measure up to what your IQ predicts it should be, then I'm going to diagnose you with a learning disability. We've moved to what's called the response to intervention model, where we see how well a child responds to repeated interventions for something like reading before we diagnose them with a learning disability. So they have to move through a pyramid of different levels of intervention before they get a diagnosis. And I could teach an entire class on that. That was what my dissertation was on, but I won't. If you want to know more, come to graduate school and I'll tell you about it. Okay. So with most of those disorders, we're looking at treatment recommendations that are mostly behavioral. You need to know about applied behavioral analysis, which is that ABC, right? Antecedent, behavior, consequence. You remember that? That ABC model, antecedent, behavior, consequence, where we're looking at the different types of behaviors that we're trying to remedy or ameliorate, and we put into place either changes in the antecedent, so change the situation, or in the consequence in terms of rewards, punishments. Know that rewards are far more effective at changing behavior than punishments, across the board. We see life skills training like occupational therapy, behavior plans like positive behavior support, token economics, externalizing time, and then we have psychoeducational for families. Okay? Any questions about those things? Those of you who've been in my classes who we've done self-shaping projects, self-shaping projects are the exact kind of thing that we're doing, right? That is a lot of what RTI is. I get a baseline measure for behavior, I apply an intervention, I see where the behavior is, I start shifting things based on that. That's what it is like. Okay, moving on. Schizophrenia spectrum disorders. Do you remember the diathesis stress model? What is it?
It basically just asked you a bunch of questions so that it understands your strengths. Nope.
Close, not really. Good guess though. Thank you for being bold, Krista.
Remember the word?
Others. Diathesis stress is you have your diatheses, right? Your genetic predispositions, your cultural predispositions, your family predispositions. Those are your diathesis. And then stressors are involved in your life. It might be low oxygen at childbirth, complicated delivery, poverty early in life. Your mother might have gotten the flu while she was pregnant with you. Those sort of insults to the development. Then they can push you over, right? You have your cup. Remember the cup, right? Your diathesis is the liquid that's in the bottom of the cup. The stress continues to fill the cup up, and then if you hit that threshold, it sort of overflows into the disorder. Remember? Yeah, and then there's that genetic environment reciprocal model where you might have some temperament predispositions that also would contribute to that, right? Okay. So your schizophrenia spectrum disorders are going to include schizotypal personality disorder, schizophreniform, delusional, schizoaffective. Schizoaffective, I think there is actually a question about that. That is when you have comorbid schizophrenia symptoms and mood disorder symptoms. So severe depression overlaid with delusions, hallucinations, positive or negative symptoms of schizophrenia. Okay? Schizoaffective is really, really difficult. the most disturbed I've ever been working with a client, the client had schizoaffective disorder. So it's very, very damaging and very, very difficult. One of the things that you need to remember about schizophrenia spectrum disorders is the difference between positive symptoms and negative symptoms, okay? So I want you to think of a baseline level of functioning, sort of how you're going about your life, how you're interacting with the world. It's your baseline level of functioning. Positive symptoms are not positive in the notion that they are great and we love them, right? Positive means additive, right? So positive symptom is something that's beyond just your baseline level of functioning in that it's adding something to your level of functioning, like hallucinations, right? So I hear the things that you say to me, but then I also hear things that nobody else hears, right? Delusions are also considered a positive symptom. So a delusion might be, I feel okay, but then I also think that I'm God, right? So I have these ideas that are additive to my experience. Where negative symptoms are things that fall below baseline levels of functioning, right? So when we say avolition, a lot of them start with A. So avolition is I don't have the capacity to do anything. Like I'm just going to sit around. I'm not going to get anything. I'm not going to solve any problems. I'm not going to do anything. The grease might be burning on the stove, but I can't really bring myself to go put the fire out, right? That's avolition. Alogia is slow movement, psychomotor retardation. Anhedonia is lack of interest, flattened affect, asociality. All of those things, when you're departing from your baseline level of functioning in that you are functioning very low, that's a negative symptom. So we often see what we call decompensation in patients with schizophrenia, and that might look like I stop showering, I stop doing any laundry, I stop ever taking out my trash, I stop doing anything social, right? So things kind of start to fall apart. Does that make sense? Okay, do you understand the difference between positive symptoms and negative symptoms? Because that was definitely one of the questions that I had. Disorganized symptoms are things like disorganized behavior, disorganized speech, derailed thinking, right? So I might start talking about one thing, and then I might just get off on a tangent and go way, way far afield, and it's sort of that stream of consciousness talk that's not purposeful or directional. When we talk about treatments for schizophrenia spectrum disorders, we look primarily to medication. We also do some family support training, and there are some CBT and mindfulness interventions that are helpful. But the first line of defense for schizophrenia, particularly for delusions, hallucinations, is going to be medication, right? This is generally recognized as a disorder for which medication is acceptable. Culturally, we have some other ideas about what's acceptable in terms of medication for depression or anxiety, but people are generally okay with that. Yeah?
Isn't that what Xanax was created for?
For, I don't know. Xanax, it lowers, it calms people down a lot. It's very relaxing. It might have been. I don't know. It's a good question. Look it up. And then we'll talk about it on Wednesday.
Okay.
It's been around a long time. Okay. Bipolar and related disorders. Here's the thing I like to take with you. As you graduate and you leave Tarleton, you move on into the world, here's what I want you to know. Bipolar disorder is not moodiness. Bipolar disorder is not the same thing as moodiness. Like my friend who gets really, really mad, she's like super nice, and then she gets mad because I touch her radio, that's not bipolar, right? Or she gets upset because her friend doesn't want to get together with her, and she gets really mad and yells at her friend, that's not bipolar disorder, okay? So those of you who had abnormal, what's bipolar disorder?
Extreme highs and extreme lows.
Yes, right. So distinct periods. Again, like we look at baseline level functioning, and everybody's baseline is different. That's important that we've got that, right? But bipolar disorder is your baseline level of functioning, and you have departures in the high, and you have departures in the low. And in the high, that looks like mania or hypomania, right? And that is like racing thoughts, can't sleep, risky behaviors, you're engaging in a lot of things that you wouldn't normally do, right? and then depression, right, or hypo, like depressive features, like lower levels of depression exist. And so you know what depression is, right? And depression doesn't have to just be sadness. Some of that alogia and some of the withdrawal can be depressive symptoms as well. All right? So you could think of it, I wish I had a marker. I don't have a marker with me today. You can think of bipolar 1. So if I have my baseline level of functioning, bipolar 1 is high manias and low depressions, really big waves. Bipolar 2 is hypomania with depression. So my highs aren't quite so high, but my lows are still there, right? And then cyclothymic disorder, which is hypomania and dysthymia, is sort of lower level fluctuations, but the fluctuations still exist, right? Cyclothymic is chronic, right? So it's a lower level, but it usually lasts, it's much longer term, right? The number one most severe is bipolar 1. Bipolar 2 is slightly milder, although people who have it might not. I mean, it's a difficult disorder. Again, for bipolar disorder, the medication is the first line of defense, right? Lithium is the one that's been around the longest. Lithium has been around a long time. Lithium has pretty high toxicity. So when we're talking about dosing people for medication, you look at an effective dose, right? So you have to get the medication in the system to where it's minimizing the symptoms, so you get to the effective dose. And then you don't want to go over the effective dose because the side effects start to get much more severe, right? But then most medications also have a lethal dose. So you're sort of walking the line as a psychiatrist between that effective dose and not getting too high over it. Well, the effective dose and the lethal dose for lithium are closer together, right? Which makes it a little bit more difficult and scary. So that's why lithium is not usually the first line medication treatment, but it does exist, and it is very effective for treating those wild swings in mood. Okay? A lot of the other treatments are psychoeducation related to medication compliance, because if you, like, there's a great video and book and series, and she's brilliant. A woman named Kay Redfield Jamison, Kay Jamison. She talks about her experiences with bipolar disorder and how difficult it was. She's a psychiatrist. She, I think, is still at UCLA. She was at Stanford. Anyway, she moves around a lot, but always to Ivy League schools, right? Anyway, she talks about why she was non-compliant on her medication for years, even through medical school, and it's because, anybody have an idea why people would not want to be compliant? Mm-hmm.
Well, aside from side effects,
Mm-hmm.
especially when you're looking at mood stabilizers and all that kind of stuff.
Yes, they're rough.
When you get manic,
They love it.
you feel great.
Yes.
There's no reason.
Absolutely. It is an addictive state. Mania is an addictive state. You feel wonderful, right? Until you come crashing down and you realize that you have wiped out your bank account, or you've done something like that would be way out of character for you, or something else. Okay. So it's difficult to get, but psychoeducation is really, really important in treatment. Okay. Then I've kind of categorized things next into terms of externalizing disorders versus internalizing disorders. So when we talk about externalizing disorders, we're looking at things like oppositional defiance, conduct, and intermittent explosive disorder, right? So these two usually there's a path, there's a progression. So and it's not everybody. So I don't want you to freak out if your nephew's diagnosed with ODD, right? But a lot of times what we see is oppositional defiant disorder is the first disorder that's diagnosed in young children. That's just children who are defiant, right? Who are oppositional. You've probably met this kid. The kid who you have to make it be their idea or it is not going to happen, right? The kid who you don't get into power struggles with, because there's no point in getting into a power struggle with this kid, right? So oppositional defiant are those kids who everything you say, it's the opposite. Everything you ask them to do, they refuse to do, but if you can get them to believe it's their idea, you can sort of work with that, right? And we see parent training and rewards are far more effective for an oppositional defiant kid, if you put them in timeout or you spank them, they're more likely to increase their behavior, right? Sometimes oppositional defiant disorder is effectively managed and treated and the child goes fine, right? Sometimes it transitions into conduct disorder, and conduct disorder is sort of this second level of that oppositional defiant disorder in which children are more likely to do things that break the law or hurt other people, right? So conduct disorder is sort of the next level for that. And it has different diagnostic criteria. Sometimes if we get really involved with multi-systemic treatment, which is pretty high level treatment where the psychologist is working with the school environment, that system, the family environment, that system, and other community supports, right? That's multi-systemic treatment. With a really high level of support, sometimes we can pull people out of conduct disorder. Sometimes not, and that transitions into a personality disorder. What personality disorder do you think is associated with that? Do you remember personality disorders? We'll talk about all of them in a second. It's antisocial.
Oh, I thought she was just about to say.
Yeah, you were in my abnormal class. You could have gotten that one. Yeah, antisocial personality disorder, which is that complete disregard for other people. And basically, the easiest way to think of antisocial personality disorder is a lack of conscience, right?
They're like really manipulative too.
Yeah.
They just get whatever they want.
Yes, absolutely.
If they're good at it, at least.
Well, and there's some pretty good evidence that a lot of the people who are in our prison system qualify for a diagnosis of antisocial personality disorder. Total disregard for the personhood and the dignity and the experience of another person. Again, like you might think of it, a lot of these disorders are difficult constructs, right? Because we're still learning in this field. A lot of that could be related to theory of mind if you think about it, right? So it could be some impairments in theory of mind as well. Behavioral interventions, especially for oppositional defiant disorder, are really helpful. I had a little boy I worked with who I was actually thinking about. I don't know what brought him up, but he was on my mind this morning when I was driving into school, and I was thinking about those oppositional defiant kids, and he had other pathologies that were going on. But one of the things that he did, when he would start to lose it, he would really start to lose it, and I think that there are times when people don't really know how to handle that, and so they are going to manhandle that kid, and they are going to bend that child to their will. So this kid was in a room. We were in a classroom. But it was not really terribly different than the way this class is structured, and luckily nobody else was in there, right? They called her we need the psychologist to come down to the counseling room, please. And so the school counselor had a classroom where she would bring students in for classroom guidance, and he was in there. And he was walking around, and he would look right at me, and he would go. And then he'd walk to the next one, look right at me, turn the chair over. And so it took a minute for me to kind of see the pattern of what he was doing. And the counselor had been like, stop, you're going to knock something, you're going to break something, stop, you're going to hurt yourself. And I was like, just ignore him. So I was talking to her, and I knew that he was really interested in Star Wars. So he had knocked over every single chair in the room and had climbed up underneath the table and was screaming, "You won't get me! You can't talk to me!" So I started drawing pictures. I just pulled out, I put a chair up far away from where he was, and I pulled out paper, and I pulled out markers, and I started drawing pictures of Star Wars characters, and I started asking the counselor really loudly questions about Star Wars characters. I was like, I can't remember, Darth Vader is the dad of all the stormtroopers, right? So Darth Vader is in charge of all, and he stopped yelling, and we were talking back and forth, and then he was like, Luke Skywalker's dad, from underneath the table. And I was like, are you sure? I don't think so. And so then he got up and he started talking, and then we got him calmed down, and then we could talk about what was going on. But if I had tried to put him in a therapeutic hold or stop him right in the middle of his fit, it wouldn't have worked, right? It would have escalated. It would have gotten way worse. And so with oppositional defiance, we have to find different ways. Yeah?
So what makes this a disorder rather than just a defiant kid? Is there a...
Yeah, so, okay, that's a great question. So with any of these disorders, are kids defiant sometimes? Absolutely. Is my kid oppositional? Yes. Everything I tell him, he said, nuh-uh, nuh-uh. I was like, we're out of milk. Nuh-uh. Yeah, yes, we are. Why would you defy me on that? Of course we're out of milk, right? So with any of these disorders, when we have this DSM-5, there's a list of specific behaviors that they have to meet in order to meet the diagnostic criteria, right? So in order for it to be classified as a disorder, they have to meet the specific criteria. They have to do this and this and this for this length of time across these different settings, right? So that's how we know when it transitions from a kid who's defiant, which lots of children are, a kid who's not responding well to traditional forms of parenting or punishment, which lots of children do, how we know when it transitions from just that into a disorder. That's the way we know that when I get super anxious about a test, I don't have an anxiety disorder, I just have some symptoms of anxiety. When I'm having a really rough day, or I just sort of generally feel down, I know that I have some depressive symptoms, but that doesn't mean I meet the diagnostic criteria for a depressive disorder. So that's a great question. And it varies by all of the different, like all of those different categories, and within each category there are all the different diagnoses. Yeah?
Okay, not to derail, but just
Okay.
a question. I read a study about the ODD kids. Are there red flags that happen, like something family-wise, or do you see it more with kids that have had more trauma or more stress? Because the study was saying something about kids not being able to handle their stress level, and so it kind of almost goes into that.
I
Or
see.
Do you see a lot of normal families
It depends.
stable? Do you get what I'm saying?
Well, because here's the problem, right? The problem is what is normal, right?
That's why stable, kind of just
Yeah.
emotionally healthy.
Right, and so sometimes there are those cases, and sometimes I see it as a mismatch between parenting style and child temperament, or parent's temperament and child's temperament. I worked with a child when I was working in a different city, and this child was very severely ADHD, but was also very oppositional defiant. And in a lot of ways, what I saw after working with the family for several months was that the mother was also severely ADHD, right? And so her impulse control in dealing with her son was just shot because she didn't have the capacity to be patient and talk him through his fits and his temper. He would escalate, she would escalate, he would escalate, she would escalate, and it turned into this big thing, right? And it's not anybody's fault. So sometimes when I would frame this to work with parents, I would say, it would be like taking your kid to they need specialized treatment for diabetes, or they need specialized treatment for cardiology. So sometimes the things that we do, just giving Tylenol and bed rest and those things aren't just quite enough, right? So we need some specialized interventions and some specialized treatment for this constellation of things. So is it related to trauma? Yeah. Can it be related to dysfunctional family? Yeah. Can it be related to poor parenting or distracted parenting, or parents who have their own pathologies? Yeah, it can be related to all of those things. And sometimes it is, like your regular standard 2-parent household, medium or middle class income, both parents are highly educated. It can just be that, right? My niece has oppositional defiant disorder. My brother and his wife have been married for years. They're happy. There's not strife in their family. She has all the things she could need. All of the things that you would think would be in place to have a completely normal upbringing, great. But she is a mismatch between her temperament and my sister's temperament. And so they've butted heads since they were tiny. And so she just, and my brother is also oppositional defiant. So it's just, sometimes there's not anything that anybody's done wrong. It's just a luck of the draw.
Yeah, I wasn't saying wrong, it's just, I was wondering if there were red flags with kids that you could, maybe even some possible predictors.
I think that there are definitely markers that would be red flags. The same way, like if I do an assessment, like an ADOS, an Autism Diagnostic Observation Schedule, with a kid who's pre-verbal, like a 1-year-old, I can still see markers for that. So I can see markers by if they don't show their parent a neat toy, like if they don't do a 3-point gaze, if they are not calm, so there are markers that I can see And I mean, I'm sure there are markers that exist for oppositional defiance as well. So like children who have a hard time calming, children who have like a really like high anxiety sort of a temperament, or who have sensory stuff, like those kids are much more likely to develop oppositional defiance.
And what's intermittent explosive disorder?
Ah, good question. Intermittent explosive disorder is, you see this more diagnosed in adulthood than in childhood. Intermittent explosive disorder is that person who goes, stony face, and then explodes with anger, right? So nothing's phasing, and suddenly this adult is punching walls and breaking his hand right next to somebody's head because he can't control it, or she can't control it. It's much more common in males than it is in females. I mean, it happens very frequently. So intermittent explosive disorder is like a pretty baseline level of functioning with sudden spikes that are difficult to predict, and just explosion of anger. Okay. The internalizing disorders, things like depressive disorders, anxiety. So we've got major depression, right? So with major depression, you have to have 5 symptoms from that menu of symptoms like we were talking about a second ago. You have to have it for 2 weeks. Persistent depressive disorder was formerly called dysthymia, which is low mood plus 2 instead of 5 symptoms for 2 years, right? So it's very chronic. And disruptive mood dysregulation disorder, which is the little boy that I was just talking about, whose mother had ADHD and he had ADHD. He also, this was him, and also the kid who knocked the chairs over. We created this well, not we, because I wasn't a part of the DSM-5 committee, but this was created because a lot of children were being diagnosed with bipolar disorder as children because they would have these temper tantrums that were way out of proportion for the stimulus of the environment. They were difficult to soothe, they were difficult to calm, they would be protracted in length. But they didn't really meet the criteria for bipolar disorder, which is clear and distinct periods of mania and depression, right? And so do we know whether this develops into those clear and distinct periods and it's just dysregulation at the early ages? This is brand new to the DSM-5, so it's been a diagnosis for about 4 years now. So the level of research that we have into it is not profound, but it's just a better fit diagnosis for those kids who aren't really on the autism spectrum but cannot manage their emotional state, right? And so we have created this new one for those kids. So it's severe and recurrent tantrums for a year before age 10, right? And they need to be disproportionate to the age. So a 2-year-old throwing a severe tantrum because you don't give them candy at the grocery store is not inappropriate for the age. An 8-year-old laying on the ground, kicking and screaming in the grocery store because you're not giving them candy is disproportionate for the age.
How do you know that they're not just being like a spoiled brat?
Yeah.
Yeah.
That was,
Yeah, it's a good question, right? And so sometimes there are kids who might qualify for a DMDD diagnosis because nobody's ever taught them to regulate their emotions. Nobody's ever taught, their parent learned this lesson early on through negative reinforcement, right? Do you remember what negative reinforcement is? Reinforcement increases the target behavior. Negative is you're trying to remove yourself from a negative situation. So these parents have been negatively reinforced to give in to the tantrum. And so the child doesn't hear no, they hear escalate, right? So yeah, they could be the product of that exact thing, but they are still dysregulated in their moods. Whether or not it's because a parent reinforced that or whether or not it's something else, they still have the pattern of behaviors. Remember, our disorders in the DSM are behavioral observation only, right? We don't have the biological markers, we don't have the neurological markers to make a diagnosis the same way a doctor would and say, there is a tumor inside you, I can see the abnormal cells. We don't have that. All we've got are biological markers. All we've got are behavioral markers. And so, regardless of whether it is the product of parenting or it is dysregulated mood that's going to develop into bipolar disorder, we would start the treatment in the same place because we're doing behavioral interventions. Because we're doing behavioral and psychological interventions, we would treat it in the same way. And it would probably be through parenting classes,
So
yeah.
is it just kind of more for insurance coding so that we can help these kids at an earlier age to possibly prevent? I mean, because if you have a tantrumed kid
Mhm.
who goes into therapy,
So,
they're almost requiring diagnoses to be able to continue treatment.
yes, and that we're going to talk about that in the context of the ethical problems with some of these things, and that is one of the ethical considerations. Insurance companies require a diagnosis, right? And is that fair or reasonable? That is an ethical debate for the nation to have as to whether or not it's fair or reasonable that in order to receive services in a way that a family can afford, the child has to be diagnosed with a psychological condition, or the family, somebody in the family does. And there are some flubs around that as a practitioner, right? You can diagnose with an adjustment disorder or something else. I can tell you as a practitioner who's worked with kids, I've diagnosed DMDD about 4 times. It's not something that I diagnose commonly because I work with kids who are the product of rough parenting and mismatched temperament and all of those things. I work with those kids a lot, or at least I did before I came here. And for those kids, I would use a different diagnostic term, right? It didn't really meet the threshold for, like, the tantrums that I was seeing didn't really meet the threshold. These are the DMDD kids are the kids who are unsuitable for extended periods of time, and they do kind of fall into a pretty distinct class. It's not temper tantrums that you would normally see, right? So anyway, that's kind of a long answer to the question of, yes, it's probably an ethical, I mean, it is probably an ethical problem, but what do we do with it? I don't know the answer to that question, right? Okay. We've also got for our internalizing disorders, the anxiety disorders, right? And so know that the anxiety disorders shake out into a lot of different areas, right? So an anxiety disorder can look like a specific phobia. It can look like social anxiety, which is that fear of being judged by other people, right? A very fight or flight response to disapproval or the perception of disapproval from other people. Panic disorder, which is those panic attacks. Agoraphobia, which is avoiding situations because you are afraid that you are not going to be able to escape, or you're not going to be able to avoid having a panic attack, or you're not, so you just stay in your environment, right? You stay in your home, or you stay in one place, or you venture out very little. Or then you also see it manifest as generalized anxiety disorder, which is sort of a general functioning level of high anxiety. Yes.
Every time I talk to someone new about my anxiety, it's like they try to diagnose me with depression also.
Uh-huh.
And I'm going to answer truthfully, but when they tell me, like, do you ever have problems getting out of bed? And I'm like, I'm a college student having 8 a.m. classes with work every day. Like,
Yes.
I'm going to have, and I'm explaining that to them. And they're like, oh, okay. Well, do you have access to weapons? Yeah. Yes, I have access to weapons. And I don't know if they're trying to do their job or if it's so uncommon just to have one instead of 41. I
think that it depends on the level of the practitioner that you're talking to, and it depends on the role in which they're talking to you. So there's a very complicated answer to that question that probably I won't have time to go into today, but different people have different roles, and sometimes it is like I need to fill out this risk assessment for suicide, and I have to put that in my file because it's a requirement for my position. If I work at MHMR or if I work somewhere else and I'm doing an intake, I have to ask those questions and get them out of the way. For other people, they may be using it diagnostically. Hopefully, the people that you're talking to are sophisticated enough to understand the difference between avolition, the inability to get out of bed because you just can't get out of bed, and exhaustion from being a college student, because there is a distinct difference in those things. So the treatments for the internalizing types of disorders are going to be things like cognitive behavior therapy, right? Do you all know, you're familiar with cognitive behavior therapy? So looking at cognitions or thinking, right? And then also behaviors. So whether or not you can get out of bed, whether or not you're sleeping at night, moving toward becoming more active and sort of forcing it, faking it till you make it, is a lot of times the treatment recommendation for behavioral therapy. For specific phobias, we have systematic desensitization. Anybody know what that is?
gradually exposing, it's like exposure therapy.
Mhm.
Gradually, you have social phobia, okay, let's go to the front yard for a little bit,
Mhm.
okay, now let's go walk down the street. Okay,
Yes.
now we're gonna go to Walmart.
Yes.
And gradually building up until,
Right, right. So when somebody comes in and they need treatment for a phobia, and I'm going to engage in somatic desensitization, and their phobia is for spiders, we're going to create what's called a fears hierarchy, right? And I'm going to show them a cartoon of a spider that I drew, and then I'm going to show them a more realistic picture of a spider. And then we're going to move toward, I'm going to bring a spider into the building, and then I'm going to bring a spider into the room, and then we're going to get to the point where through behavioral interventions and keeping you calm through these graduated exposures, you're able to let a spider crawl on your arm.
you had to pick spiders.
Sorry. Every time I choose an example, it pulls a string with somebody in my class. Like, I did clowns one time in one of my classes, and people were like, no, spiders, no, right, heights, any of those things. They're so common that I always strike a nerve with somebody, right? So this ABCDE model right here, this is different ABCs, right? This is the act. You can't really read it very well. For this one, this is the CBT model. So you have an activating event, and people a lot of times believe this is from adjustment and abnormal both. I've talked about it in both my classes. But you have the activating event, somebody bumps into me. You have the consequence, the emotional consequence. I'm going to fight that, right? I bow up. Don't bump into me. You made me mad, right? But we forget that the B are the beliefs about the event, the cognitions that we have that are associated, right? You don't care about me, you're disrespectful toward me, you right? All these attributions that actually cause the emotion, right? So in CBT, we start working on those cognitions. We draw those automatic thoughts, those beliefs about the events into awareness so that we can start to modify those things. This is the CBT cognitive triad, which is supportive of depression. So we use this a lot in depressive treatment. So negative views about the world, everybody's against me. Negative views about the future, I'm never going to be good at anything. And never negative views about myself, I'm worthless and inadequate. So we work at trying to modify each of those different belief structures. Okay? Questions about that? In case you are wondering, IPT is interpersonal therapy. So that is looking at your role and role transitions and how you interact with other people and working through those interactions to make you feel more competent or happy. Okay, so another thing that I want you to make sure you take away from this class or your time as a psychology major is that if I'm neat, which I'm not, and everything in my desk is in the right spot, and I always have to have it at a certain temperature, and I'm just really particular about how things are, I am not obsessive compulsive. That is not OCD, right? I'm not OCD about the arrangement of the radio stations on my dial. I'm not OCD about how often I take a shower even. Those things by themselves are not OCD, right? It might be OCPD, which is obsessive compulsive personality disorder, which is a completely different thing. But obsessive compulsive disorder requires you to have two components. What are they? On the board. Obsessions and compulsions, right? You have obsessions, which are thoughts that are uninvited, unintended, things you don't like. Those thoughts come on unbidden, and you use your compulsion, the behavior, to mitigate that. A lot of times this is related to sort of magical thinking, right? Or constant reassurance. So a really common one is, a common obsession and compulsion is, I think I might have driven over somebody. I might have hit somebody in my car, so I'm going to circle the block 5 times to make sure that there's not anybody there laying in the grass. I think I might have hit somebody. Anytime you hit a bump in the, that's a common one. Another common one is germ related, right? So I have to wash my hands every time I touch anything. If I touch the doorknob, I have to go and immediately wash my hands. So if you have true OCD and you watch me go like this, and then you watch me go like this, you all have OCD, right? It creates real discomfort, right? And so, in order to relieve the discomfort, you have to engage the compulsions. I might have to touch my doorknob 6 times. I might have to touch everything I pass 6 times in order to suffer something bad not to happen to my mother, right? The obsession is if I don't tap things 6 times, something bad's going to happen. And you see it sort of, you can see it start early on, right? Have you heard, don't step on a crack or you'll break your mother's back? And have you seen As Good as It Gets? Like he walks down the street and he can't step anywhere because he can't step on any cracks at all in the sidewalk. So those kinds of things. Do you have a question? Okay. So you have to have both the obsessions and the compulsions. You are compelled to act on those. So the treatment for that is exposure and response prevention, ERP, right? So then I go make you touch the doorknob and then touch your face, right? Usually it's more like you do it, you structure that type of treatment like you would systematic desensitizations. I'm not going to make you do things that you can't do without giving you a skill set to be able to do that competently. Okay?
Are they thinking about changing something with OCD because it's so commonly spoken about and people say, oh, you have OCD?
I have not heard of any movements to change it. It is really commonly misspoken about, and I try to, I get on my soapbox about that. I get on my soapbox about bipolar disorder. And I get on my soapbox about Rose's Law and intellectual disability. So those are the ones that I get on soapboxes about. So we have then trauma and stressor-related disorders. There is a difference between PTSD and acute stress disorder, right? So PTSD occurs, those are the symptoms like these are some of them, that last for more than 1 month after the trauma. Before that, it's called acute stress disorder, and really it's not so much a disorder as it is a common reaction to stress, right? If you're involved in a car accident and you're very severely injured, you absolutely will have intrusive avoidance, negative alterations, all of those things. You are likely to. Yes?
What if you are literally scared every time you get in the, like you can be in the car, but I cannot be in the car with my mom after my car accident because she gets way too close and I tense up.
Mm-hmm.
And for like a good month after my first wreck, I had nightmares about it.
Right, so that would be changes in arousal and reactivity, right? Because you didn't act that way, you didn't feel that way before, but now you have that, right? And so if you're seeing other impacts, so again, like the other ones, some level of this is normal, and even some level of this is normal beyond 1 month after the trauma. Because who decided 1 month after the trauma was the designated length of time? Who decided that it's 3 months before you're diagnosed with protracted grief, right? And who decided that 3 months was the appropriate amount of time to grieve? And then after that, you should be back to your normal life. So there are some things that are a little bit arbitrary, right? And so in order to meet the diagnostic criteria, you have to have a certain amount of the symptoms for a longer period of time. But they also have to be significantly impacting your functioning. If it's one circumscribed area of your life and you're still functioning completely normally outside of that, you could absolutely seek treatment for that. Some systematic desensitization might be the right way to go, or prolonged exposure therapy or something like that. But it might not meet the diagnostic criteria for PTSD. Does that make sense? But it's not unusual, especially after a pretty traumatic event, for there to be lingering things. But if it's impacting your life, that's when you seek treatment. So the most common way I see this manifest, the most common types of work that I've done with PTSD have been with returning veterans, right? And we have lots on our campus. And the most common way I see people treating it themselves is through self-medication, through alcohol or something else, right? Or I see it for like first responders, police, fire, those kinds of folks. And people mostly engage with self-medication. But there are some really effective treatments. And so whenever people would come in to work with me, I would really try to instill hope, because a lot of times what has happened is they've given up hope that they're ever going to feel normal, that they're ever going to be able to manage these emotions. So we know that prolonged exposure is really, really effective. Mindfulness, CBT, the one that's really popular right now in counseling worlds, not psychology worlds so much, right, because there's a difference, is EMDR, tapping, yeah, tapping is another one. And really there's been some research. So EMDR is actually listed in the evidence-based interventions. EMDR is eye movement reprogramming. Anyway, you move your eyes back and forth as you're talking through it. And what we're starting to look at is, so there's been research that has been done now in labs looking at what is the effective component of that. And the eye movement is not really the effective component. The fact that you're doing prolonged exposure or imaginal exposure is what's effective about EMDR. So you don't actually necessarily have to do this back and forth thing. But here's the thing, and I say this to especially parents who have kids diagnosed with autism, but all along the way, I say to them, you do what works, right? The research is the research, and it exists, and it gives us a framework for understanding. But if you find something that works for your family, you find something that works for you, you find that EMDR works for you, you do it. You do what works. You do what you need to do. You do what you need to do to take care of yourself. So if you find that the eye movement is better than just talking about it, I am not going to tell you not to do it. If you find that tapping is really helpful, then do it. Do what you need to do to be able to function well. And if I can't treat you because I don't have the training in that particular area, then I will refer you on. The only thing that I get worried about is when parents invest a lot of money, or people invest a lot of money in treatments that have been clearly proven to be ineffective, and they're very, very expensive, and they're allocating their resources to those treatments as opposed to ones that have an solid effect base. So, all right. Dissociative disorders are those disorders where you are outside of yourself. What is the most common origin or genesis for a dissociative disorder, particularly DID, dissociative identity disorder? Severe trauma, yes. Severe trauma, right? It's trauma to such a degree that your sense of self fractures, right? So that you can't handle the trauma that you're experiencing in your life, so your sense of self fractures. And this self manages the trauma, and that's not the same self as you, right? So this is usually the product of severe trauma, although some of the lower levels, like depersonalization and derealization, can be the result of some popular drugs that exist, right? So you can experience depersonalization or derealization where the world doesn't feel real, man, right? You can experience those things with things like pretty common drugs, marijuana. You can certainly experience it with LSD, like popular drugs. I don't know if they're popular. This might not be the best terminology, common street drugs. But anyway, so these are a little bit more common. This is really, really rare. It's super popular, right? People are fascinated by it. So they have movies like Split or Sybil or Seven Faces of Eve or whatever it is. But there's not efficacy studies that demonstrated a clear treatment direction. But generally, treatment of trauma, integration of alters is the course of treatment, but it's a highly specialized field. So if you came in and asked me to treat you for DID, I would say, I'm a general practitioner and you need a cardiologist, right? So it's a really specialized field of treatment. Yes, I would work really hard to put you in where you need to be.
Isn't there a study out about like shrooms or something helping with people with depression and stuff like that?
Yeah, so there are. So psilocybin. There are some really, really interesting treatments or studies that are looking at that as treatment for intractable depression. But it's really specifically guided, and the studies are really limited, right? Because our DEA doesn't like for us to do treatment experiments like that, right? Our human services review boards and stuff like that are not super keen for us to give people unproven drugs. So it's a little bit harder to find. And there's a lot of, if you read about it online, because the quality of information you get online can vary pretty widely. So there are some people out there who really believe that because Big Pharma can't benefit from natural types of treatments like cannabis oil or mushrooms or things like that, that those treatments aren't fast-tracked by the FDA, and so then they're not approved by the FDA because there's nobody bankrolling those. And I don't know how wrong that is. I don't know how right that is. I have some qualms about FDA stuff. There are some really interesting books about it. Unhinged by Daniel Carlyle is one. But yeah, so there are some and PTSD too, trauma treatments. So yeah. Dissociative amnesia is when you forget who you are, and fugue subtype is when you leave. You're just gone. A fugue state is you don't remember who you are, you don't remember how you got to where you are, but you're somewhere far afield from where you're supposed to be. Somatic disorders are those disorders that are physiological, but that we don't have a physiological origin for the disorder, right? So illness anxiety disorder used to be called hypochondriasis. You've heard of that, right? Like my grandmother thought she had cancer for 40 years, and no doctor could ever find it, but she kept going to doctor after doctor after doctor looking for the diagnosis that she was sure she had, right? Conversion disorder. So conversion disorder might look like PNES is non-epileptic seizures. So somebody who has seizures, but they don't have the same type of brain activity. And a lot of times we see that tied back to trauma as well. It's a physiological reaction to a psychological stressor, right? So sometimes I think there's a miscommunication or a misperception out there that people are faking these types of things, and like especially with PNES, it's important to note that that's not something somebody's faking, right? There's probably some really complicated origin for what's going on, but just because it doesn't look like an epileptic seizure, that doesn't mean that it's not a very real physiological experience. It's very different from malingering, which is intentionally faking things for a clear gain, right? So if I'm going to try to claim disability and stop working because I have PTSD and I don't actually have PTSD, that's malingering, right? And that's different still from factitious disorder, which is falsification of symptoms without a clear evidence of gain, right? Maybe the gain is being the sick role. Maybe the gain is the attention I get from whatever. That's faking without a very clear gain. Yes?
The parents who intentionally make their kids sick and stuff for attention, would that fall under one of those?
Yes, so that's called factitious disorder by proxy, formerly known as Munchausen syndrome by proxy. So that is when a parent fakes illness in their child, and it's very, very, very difficult to identify and treat because people doctor shop. So if somebody sort of is onto the game and they just switch doctors so that they can continue receiving whatever the psychological payoff is. I work with one of my former mentors. She works for a children's hospital, and they're working hard to try to get enough documentation to report to the Department of Social Services a case of factitious disorder by proxy, but it's really difficult because any questions that they ask, the parents get a little spooked, and then they might run, right? And so in order to establish the medical documentation, it's really difficult. It's very, very difficult to identify, to treat. So treatment involves primary care identification and intervention. So usually it's CBT or something else for underlying trauma. Yes?
Somatic versus somatoform.
Okay. Hold on just a second. Let me get my mind around that. I really don't want to tell you the wrong thing because I deal with this so infrequently.
That was one of the questions on like the book guide help practice thing.
Yeah.
I kept getting it wrong and I can't wrap my brain around it. So.
Okay. Do you mind if I go ahead and look that up? Because I really don't want to get it wrong. I think that, do we leave at 10:15? Well, curses, y'all, I'm not done. Okay. I was thinking I had till 10:30 because I don't know what day you meet or how long you meet or anything else. Sorry. Okay, so somatoform I think is when you have like left side paralysis related to possibly trauma or something so you have like an actual physiological problem where somatic symptom is you are complaining of something and they can't find the, let me look it up.
I think you got it backwards there.
Oh, did I? Okay.
It says disorders are a group of psychological disorders in which a patient experiences physical symptoms that are inconsistent with or cannot be fully explained by any underlying general medical or neurological.
It's really interesting because I think it's worth talking about. So we'll talk about it on Wednesday because there are some that are like blindness, that is psychosomatic blindness, where if I were to throw like you can't see anything, right? And I start to do a test, but then I throw a ball at your face and you have a reflex to catch it. Or there are things where like there's some neuro tests for like left side paralysis where I'll hold your arm up and drop it and watch how you drop it, and the way your arm falls will give me some clues. So that's really, really a broad and complex field, and I really don't want to mislead you. So let me look it up and we'll come back to it. And then eating disorder, substance, parasite, oh my gosh, so many things. So we didn't get very far. We'll keep talking.
Physical severe and